You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 12th, 2024. This week, listener feedback on venous closure devices, GLP1 agonist and blindness, GLP1 agonist and cancer, resisting the urge to do an ECG, and transcatheter edge-to-edge repair for secondary MR. Welcome back, everyone. I want to do a quick reader feedback on my June 28th discussion of vascular closure devices. I reported on an observational study of venous closure devices after AF ablation, but a listener sent me notice that there was an actual RCT on these devices out of the University of Lübeck. It's called the Style AF trial. It was published in Europace, and first author Dr. Roland Tills. They compared venous closure systems to figure-of-8 suture and manual compression after AF ablation. It was a small study of 125 patients, and they found that the device arm had shorter time to ambulation, a lot shorter actually, 109 versus 269 minutes, a shorter time to hemostasis, shorter time to discharge. They also found the trend towards fewer minor vascular access complications. Major complications were not different. Now, I like trials such as this, right? It's small. The primary outcome, the time to ambulation, is a surrogate, okay? It's unblinded and it's funded by industry. But at least a treatment is randomized, and we need more of this in medicine. Now, the authors rightly conclude that closure systems improve the surrogate outcomes. I would note that less than 10% of patients in this arm received protamine or heparin reversal. I think this is an important baseline characteristic or trial procedure because not receiving protamine would surely favor a closure device. We, at our center, reverse heparin in all cases. They also found no difference in same-day discharge, which was about only 15%. That's also different from many labs in the U.S., which send patients home on the same day. The authors don't emphasize the massive difference in cost. So I stand by my previous take that spending many hundreds of dollars for a few minutes shorter time to ambulation hardly seems worth it. The figure-of-8 stitch with the stopcock instead of the knot remains, I think, one of the most elegant techniques in all of cardiology. All right, next topic is GLP1 agonist drugs and the issue of a rare eye complication. Well, since the placebo-controlled SELECT trial, which I've covered previously, found that semaglutide reduced cardiovascular outcomes in patients with established heart disease and obesity, GLP-1 drugs can now be called disease-modifying agents in patients with heart disease, and that is big. Also big is the vast number of patients who will be eligible for these drugs. One other observation, the drugs seem to require constant and long-term usage because patients who stop the drug gain weight back. Plus, why would you want to stop a disease-modifying drug? Okay, one important issue, not just for individual patients, but also for public health, is the possibility of long-term adverse effects. RCTs are done for efficacy, they're done for a handful of years, but if millions, perhaps billions of patients take these drugs for decades, even a low-incidence adverse effect could be important. I'm going to always cite Professor Rod Hayward, who wrote in Circulation Outcomes that even statin drugs have unknown unknowns when it comes to decades of use. The same holds true for GLP-1 agonist drugs. RCTs will not be useful for the detection of low-incidence adverse effects, mainly because they go on for years, not decades. If we are to detect low-incidence adverse effects, we're going to need observational data. 2 studies published recently since the last podcast purport to detect signals from GLP-1 agonists, but both studies fail miserably at that goal. And why and how they fail are instructive for those interested in critical appraisal. JAMA Ophthalmology published the first study. This was a matched cohort study of 2 groups of patients who presented to a neuro-ophthalmology clinic at Harvard Medical School. The authors concluded that there was a possible association between semaglutide use and a rare but serious cause of blindness called non-arteritic anterior ischemic optic neuropathy. This is abbreviated NAION. And before this week, I had never heard of this condition. In fact, it's pathetic how little understanding I have of the human eye, even though I see eye doctors often for my farsightedness. NAION, I have learned from Google and YouTube, is the second most common form of optic neuropathy, and it's a significant cause of blindness among adults. Now, nearly 250 news outlets covered this JAMA Ophthalmology paper with headlines such as weight loss drug linked to rare cause of blindness. The altmetric score, as of yesterday, was a massive 2,300. Thing is, 2 doctors, each of whom I respect greatly, sent me the paper, but for opposite reasons. One smart doctor sent me the paper because it was methodologically so poor. He said not only cardiology studies are bad methods. The other doc sent me the paper because the findings were quite interesting. Now, here's what the mostly eye surgeon authors did. They write that the study included more than 16,000 patients referred to their specialty clinic, but this is misleading because the actual study included 770 patients with diabetes and 980 patients with obesity. Of the 710 patients with type 2 diabetes, they then separated nearly a third who had semaglutide exposure and 2/3 who had their diabetes treated with non-GLP drugs. And they did the same for the 980 with obesity. About a third had used semaglutide and 2/3 did not. They then did matching of the 2 uneven groups based on a few but not all covariates. Now they looked back at how many in each group had the condition NAION and how many did not have the rare eye condition. What they found was that the incidence of NAION in patients with type 2 diabetes or obesity was about 4 to 6x for patients who had semaglutide exposure versus non-semaglutide patients. They displayed the Kaplan-Meier curves with a y-axis cropped from 90% to 100%, so only 10%, not 0 to 100%. So, my comments. I worry about the long-term effects of GLP-1 agonists. If this were a true association, it would be very worrisome. But my gosh, this is not the way to find out. First of all, there is a huge collider bias, right? As these were patients referred not just to an eye surgeon, but a specialty neuro-ophthalmology clinic at Harvard. If you are referred to such a clinic, you are a special group of patients. Dr. Brian Locke, an intensivist at the University of Utah, noted on Twitter that you could see an apparent increase in the hazard of the eye condition if GLP-1s reduced the risk of other causes of ophthalmology referral. Both groups had to have some reason for referral in order to be included. So event-free is actually another referral trigger. He said that if patients receiving GLP-1s were referred faster after starting their new medicine than others, which of course is plausible as they managed to get on GLP-1s, that would also lead to the finding, since the authors analyzed the hazard ratio as a ratio less exposure time before the diagnosis. And finally, Locke notes that it doesn't even have to be a causal reduction. If patients on other meds are more likely to be referred for other types of issues that aren't balanced by their matching, that could also explain it, especially when access to GLP-1s is limited, because those likely have very different ocular issues. My friends Dr. Bogdan Inaki, an EP doc in Romania, and Venk Murthy, a professor of cardiology at University of Michigan, noted the problem with time zero and immortal time bias that this study has. This occurs because the authors calculated person time from the first prescription of semaglutide versus a non-GLP-1 diabetic or weight loss medicine. If something else caused the eye issue, then people on the newer drug will have a higher rate on the person time scale. Other problems. The effect sizes are huge, but they calculated not from a general population, but from a highly selected groups of patients from a Harvard referral eye clinic. The authors even calculated the incidence of this condition by dividing the rate of the NAION rare eye condition by the number of patients in the sample at the clinic. This is beyond comprehension, since the overall incidence of this eye condition is super rare, like in the 1 in 10,000 range. Another issue, they don't control for diabetes severity. Semaglutide is used in more advanced cases of diabetes. That's important because type 2 diabetes and obesity are risk factors for the eye condition. Another problem, they propensity match, which is a really weak way to approximate comparable groups. Even if you believe there is a real association, which I don't think there is a really good chance that these are not truly matched patients. Finally, there is a wide confidence intervals and an early huge signal that then plateaus. To me, this suggests a different patient population. Now, before I close, I want to make a meta comment. That is, this paper gets published in the JAMA journal, then JAMA promotes it, then it gets a big media coverage. I think it's all deeply problematic. Perhaps this is 99% due to incentives. Incentive to do such a flawed study. Incentive for the journal to publish it because of the attention, and incentive to cover it in the news. I don't have the solution to these abnormal incentives, but one start could be that some journal editor somewhere just says, no, we aren't doing this. Now, if you wanted to know if the drugs cause this rare cause of blindness, you would need a far more rigorous observational study. Perhaps a study using the Danish registry could allow for detective associations in large populations, but surely not a small series from one specialty referral center. All right, next topic is GLP-1 drugs and cancer. JAMA Network Open has published an equally dubious study looking at the question of GLP-1 exposure and cancer. The thinking goes that the obesity likely causes cancer, or at least obesity strongly associates with cancer, and GLP-1 drugs reduce obesity, so the question becomes, do GLP-1 drugs reduce cancer? Again, such a GLP-1 drug and cancer signal is unlikely to be found in RCTs because of the short duration of RCTs. So authors from Case Western in Ohio used a large electronic health records database of millions of patients over many healthcare organizations. They then searched the database, find 16 million patients, and of those 16 million patients, 1.6 million have type 2 diabetes, who had no previous diagnosis of cancer, and these patients were prescribed GLP-1 drugs, insulins, or metformins during a 13-year period. Their primary outcome measure was the first diagnosis of 13 different obesity-related cancers. They then made two main comparisons: cancer rates in those receiving GLPs versus those receiving insulin, and those receiving GLPs versus those receiving metformin. Compared with insulin, GLP-1 treated patients had a significantly lower risk of 10 of the 13 obesity-associated cancers. Some of the lowest hazard ratios were for gallbladder cancer, meningioma, and pancreatic cancer. The incidence of gallbladder cancer was, however, 0.02 versus 0.04. So the difference was less than 10 cases per 50,000 patients treated with the drug. So again, that reveals a hazard ratio of less than 0.5, so more than a 50% reduction. But again, you're talking about 10 cases in 50,000 patients. Now, compared with metformin, GLP drugs were not associated with lower risks of most cancers, except GLP-1 drugs was associated with a 50% higher rate of kidney cancer. But the incidences here were, again, very small, 0.78 versus 0.55. So if you put that on relative risk, it's 54% higher, but you're talking about very small differences. Now, the Kaplan-Meier figures for the two positive associations, that is colorectal cancer and liver cancer and GLP-1 versus insulin, show the major flaw of this paper, and that is there's immediate separation of the Kaplan-Meier curves. In other words, the authors published the fatal flaw in their main figures. And I say fatal flaw because there is no way that GLP drugs have an immediate effect on cancer. Now, it's an open journal. Go look at the figures yourself. Again, my friends, we need to have information on these drugs over the long term. But such electronic health record care mining is not the way forward. I am not a trained epidemiologist, and perhaps you're not either, but when you see curves separate basically at time zero, it's very likely that these are different types of patients. Another meta comment. What the heck is going on in the JAMA family of journals? Perhaps there just needs to be fewer journals. Totally. I think that really flawed data like this is worse than no data. All right, next topic, the ECG. I am emotional about ECGs. Reading ECGs is one of the reasons I learned to love cardiology. Dr. Charles Fish at Indiana was a mentor, so it pains me to say something less than positive about a study on ECGs. JAMA Internal Medicine has published an observational study looking at the impact of ECG screening in working-age people in outpatient clinics. Now, you might wonder why such a study is needed because we have oodles of studies that have found associations between ECG abnormalities and future cardiovascular outcomes. The authors write that few have looked at general populations and few studies have provided a gradient of risk on how many or how severe the ECG abnormalities are. And the authors created this gradient of abnormalities by saying there were minor and major ECG abnormalities. In the supplement, they provide a list of these things. A PAC, or nonspecific STT changes, are minor abnormalities. For instance, a left bundle branch block or AFib are major abnormalities. But I have to say that list they provide is quite arbitrary. The authors from Harvard and Kyoto University in Japan used a large Japanese insurance database covering many millions of people. In Japan, it turns out, the authors write that every year insurers are required to provide their employers with opportunities for health screenings. Employees who undergo screenings receive their results directly from the screening facilities and must report them to their insurers. And those diagnosed with major ECG abnormalities are advised by their insurers to seek further examinations, which are covered by the health insurance. So this was a big data type study, more than 3.6 million people in the database, mean age 47, so working age people. Primary outcome of interest was overall death, MI, stroke, or heart failure. And here were the findings. Of the 3.6 million patients in this database, 17% had one minor ECG abnormality, 4% had two or more minor ECG abnormalities, and 1.5% had one major ECG abnormalities. If you had one minor ECG abnormality over 5.5 years of follow-up, your hazard for the primary outcome was 1.19, so 19% higher. For two or more minor ECG abnormalities, the risk was 37% higher. And if you had one major ECG abnormality, then your hazard was 1.96, or almost twofold more than you would have had versus a normal ECG. However, here we have relative versus absolute risks come up again. To give you an idea on absolute risks, if you had a normal ECG, the incidence rate of the composite outcome of death, MI, stroke, or heart failure was 93 per 10,000. For one minor abnormality, it went up to 129 per 10,000, and for a major abnormality, it was still 266 per 10,000. I know that is a ridiculous amount of numbers, so the delta in risk between a normal ECG and a major abnormality is about 1% over 5.5 years. The authors conclude, again, in JAMA Internal Medicine, the findings of this study suggest that the potential role of routine ECG screening for early prevention of CVD events, along with an optimal follow-up strategy, should be examined in future studies. My comments. I don't agree with the author's conclusion. This data does not suggest any role for ECG screening for early prevention of cardiovascular disease. All this data says is that there's a very small increase in absolute risk of a cardiovascular outcome for patients with varying degrees of ECG abnormalities. You could do a similar correlation for many things. Age, for instance. I would argue that getting older is a risk for future cardiac events. Now, even if these numbers were real and accurate, how does a working age adult with a nonspecific ST changes use the fact that his risk for a CV outcome is 5 in 1,000 higher than if he had a normal ECG? All this can do is scare people. Screening always creates tension in my head, though. Here is why. The vast majority of people getting an ECG for screening will have no effect. It'll be normal. A large group, though, will be referred for further testing. Many of these further testing cascades will tend to overdiagnose, overtreat, and even harm. I could tell you stories about how shadows, simple shadows on an echocardiogram, have led to serious harm. And don't even get me started on how many ECGs would lead to coronary artery calcium scans and then the downstream shenanigans from that. But then again, and here's the tension, on the other hand, it would be of value to discover a person with left bundle branch block, a 50-year-old with left bundle branch block, for instance. That person might have an ejection fraction of 35% and not know it. And that person might benefit from guideline-directed medical therapy. I've seen that too. Now, a good exam might sort out reverse splitting of S2, but few clinicians have that skill anymore. Now, considering the major ECG abnormality, atrial fibrillation, we have some data on screening for AFib, which is not even a minor ECG abnormality, it's a major ECG abnormality. We now know that 2 robust screening trials, the LOOP and Stroke Stop study, failed to find substantial benefits of screening for AF. And I know Stroke Stop was slightly positive, but the difference was tiny. If you can't show benefit from screening for a major abnormality in high-risk people, then it's extremely unlikely, I would say probably impossible, that screening would be positive in an all-comers working-age population. So, even though I love ECGs, and I think it's one of the most underrated tests in all of medicine, I don't love this study. The ECG is a wonderful tool for sorting out diagnoses of people who come to us with complaints, people who are asking for our help. ECG screening, though, will be unlikely to improve health. Consider, for example, the time spent explaining a PAC could be used to explain the benefits of exercising every day. All right, another topic, transcatheter edge-to-edge repair for secondary MR. One of the great mysteries in cardiology right now, in my mind, is the story of transcatheter edge-to-edge repair of secondary MR, otherwise known as the Mitral clip. Now, as an electrophysiologist, I'm an outside observer. But the MITRA-FR trial, which was a non-industry funded trial, found absolutely no benefit from this mitral clip in patients with secondary MR. However, the industry-sponsored COAPT trial found that the clip was amazing. The effect size in COAPT was akin to clean drinking water and sanitation on tuberculosis a century ago. It was a massive effect size. And of course, I know. Dr. Milton Pachter explained the difference in the 2 trials on proportional MR. And I guess that's possible that COAPT enrolled patients who were perfect for the clip and MITRA-FR didn't. But I come from Indiana University, where Dr. Feigenbaum banged into our heads how hard it was to grade mitral regurgitation, or aortic regurgitation for that matter. Neutral Martians who look at the 2 trials' Table 1 of baseline characteristics have trouble seeing any difference to explain the widely disparate results. So we learned this week that the ESC meeting that's coming up in London will feature a 3rd trial of transcatheter edge-to-edge repair for secondary MR. And before I tell you about the Reshape HF2 trial, let me just send an aside to the Impella proponents who canceled their 2nd trial in cardiogenic shock after the results of just one trial, Danger Shock. Danger Shock was a great trial, but it's not great enough to have canceled the Recovery 4 trial. Now, I've discussed this on the June 21st podcast. Now, the Reshape HF2 trialists have published both their rationale paper and their baseline characteristics paper. This trial is going to compare MitraClip to medical therapy, much like Mitra-FR and COAPT. But it may not exactly be a tiebreaker because Reshape will have far fewer patients with severe MR, less than half of the patients. Reshape will also have a slightly less effective regurgitant orifice area, basically, in general, less sick patients with functional mitral regurg. There was also a change in the primary endpoint. The original design had a composite of total heart failure hospitalizations and CV death during 2 years of follow-up. This was similar to COAPT and Mitra-FR, though Mitra-FR primary endpoint was at 1 year. An interim review of Reshape found that all-cause mortality rates were trending lower than expected. Recall that they were enrolling less sick patients, so this is not unexpected. When this happens, trialists have other options. They can extend the follow-up, recruit more patients, or change the endpoint. The authors decided to randomize more patients, which is fine, but then they also changed endpoints, added endpoints. More patients doesn't bother me, but the change in endpoint surely did. The two extra endpoints are total heart failure hospitalizations as its own endpoint. Remember, that's part of the composite, but total heart failure hospitalizations will now be N primary endpoint. And they also changed to another N primary endpoint, KCCQ score change from baseline. They will then use something called a Hochberg procedure analysis, which sounds like something like a modified Bonfieri procedure. And I found this copy and paste from a statistics site that they write, the calculation of adjusted p-values in the Hochberg procedure involves comparing each individual p-value to a critical value or threshold. The critical value is determined based on the desired false discovery rate in the control arm. Now, like you, I like learning new statistics approaches, but I'm really worried about this change in endpoint. Both the heart failure hospitalization and KCCQ endpoints are problematic. Heart failure hospitalizations is a problematic endpoint because it requires a decision from a clinician who will likely be aware of a patient's treatment arm. Now, this is not a nefarious bias because if a doctor knows a patient has a clip, they may be more likely to send the patient home on diuretics rather than admit the patient. And of course, you can't blind caregivers because clips stick out like a sore thumb on an echo. The KCCQ endpoint is way worse because you can't measure quality of life indices without a proper sham control. In these trials, in Reshape HF2 trial, one group will get a major intervention and the other group will not get that intervention. It boggles my mind that medical scientists repeatedly try to convince us about quality of life endpoints without proper controls. We shall see the details at the ESC meeting, but I would encourage all listeners to look closely at the hard outcomes in Reshape HF before making any kinds of conclusions. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to write us a review, give us a rating. These help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.